All right, good afternoon and welcome to the webinar. I am Cassidy Avila from the Center for Optimizing Women's Health at Texas A&M University. Thank you for joining us today for Improving HCAHPS Scores, presented by Stroudwater Associates. I will introduce our speaker in just a moment, but I want to let you know that we are going to be leaving time at the end of the presentation for questions. So feel free to go ahead and type your questions into the chat if you would like to do so, or you can wait until the end of the presentation and type them in. You may also unmute and ask questions or send them to me, Cassidy Avila. You can select my name from the drop-down box and chat, and I'll be happy to ask those questions on your behalf. We are recording the webinar, and we will make a copy of this recording available to you, as well as a copy of the slides. We usually get those out within about 24 hours of the presentation, so you'll get that in an email from us. Now, I would like to take just a moment to introduce our speaker. Dr. Carla Wilbur is an accomplished nurse administrator with a strong background in critical care, education, lean process improvement, and emergency services. She joined Stroudwater in 2014, and she focuses on supporting rural providers in quality and operational improvement initiatives. She's completed numerous facility assessments and process improvements in quality, care management, emergency department, and critical transitions for critical access hospitals, rural and urban health systems, and provider groups. Currently, Carla leads process improvement efforts in the development of clinical care delivery spectrum and workflow optimization. Carla is passionate and advocates for combating the opioid pandemic and is a leader of the Stroudwater Opioid Management Team. She's also joined by her colleague, Lindsay Corcoran, today, who I think will be dropping in a few comments. And Lindsay is an accomplished consultant and practice management professional with Stroudwater and has over 10 years of healthcare and medical office experience. So welcome to both of you. Thank you for being here with us today. We're really excited for the presentation, and it's all yours.
Thanks, Cassidy. I will definitely move the my screen off here, myself off the screen, so that I have some more room to look at different things. So glad to be here with you guys today. Really appreciate it. And yeah, I hope my colleague Lindsay will jump in there if there's something that that she would like to speak to. We've done a lot of work together over the years in quality and of course containing a lot of HCAHPS improvements. So what we'll do is a little overview of CAHPS, some HCAHPS best practice actions, establishing high standards of service excellence, which definitely relates to your HCAHPS and HCAHPS reporting scores, and then role of empathy, which definitely has an impact on your scores as well. So what is CAHPS? CAHPS stands for the Consumer Assessment of Healthcare Providers and Systems, and the surveys reside in the CMS Patient Experience family of surveys. So CMS has developed a whole list, and I'll show in a minute, of different types of surveys around patient experience. All surveys officially designated as CAHPS have been approved by what they call the CAHPS Consortium, and that is overseen by AHRQ. The CAHPS surveys are an important component of CMS's effort to improve healthcare in the United States. So this is just a list of all of the different CAHPS, and they may have come out with a couple more since my last data. But what we're focused on today is the hospital CAHPS. And that's the HCAHPS. So that stands for the Hospital Consumer Assessment of Healthcare Providers and Systems. And this survey was designed to make sure that we can produce some data around patients' perspective of their care. That seems to be objective, and it has a meaningful comparison for hospitals on all of the topics that seem to be important to the consumers. The survey originally, prior to the HCAHPS survey, our hospitals may survey or may not. And there were there were mixed types of surveys. I mean, most of our hospitals would do some homegrown surveys. Sometimes they would send them to their patients, and sometimes they would ask them to fill them out before they leave. But there was no way for us to compare each other and see how we rated against others within, within our state, region, or even within the country. The public reporting of the survey results were meaningful. The real pressure behind the hospitals, it was, hey, we need to improve our quality of care. And this was an incentive for them, because if their data was publicly reported, well, you don't want to be shamed by bad HCAHPS data. So that was a real push for the hospitals. Again, enhancing that accountability in our healthcare. These scores are transparent and it shows the quality, or what is thought to be the quality of care provided for our public. The instrument is 29 items. That is the data collection methodology. It does use the apples to apples approach, because all of the base core questions in the HCAHPS survey are the same for every hospital. The survey is administered between 48 hours and 6 weeks after discharge. This is to a random sample of adult patients. Now, in our small critical access hospitals and rural hospitals, most of the hospitals choose to not do a random sample, but to sample all of our inpatient discharges, since we have a lower volume. In addition to English, our survey is also available in many other languages, as you see there. The survey originally was implemented in 2006, which gave the hospitals a couple of years. And I will never forget when this first came out, we were just really upset that we were going to have to show quality data publicly, but it all turned out okay. But we had a couple of years to kind of get into the groove. And then the public reporting of our scores started in 2008. The latest data that we have in the March 2021 HCAHPS update shows that in 2020, we had approximately 4,517 hospitals that participated in HCAHPS, and approximately 7,700 patients are surveyed every day. When you think about that, it's pretty staggering. The latest information that we have around the administered percentage shows that the mail was about 74%, telephone 26%, and then that was followed by what we call mixed method, which is the mail followed by telephone, and then the active interactive voice response. In July of this year, the HCAHPS mode experiment that was done in 2021 was released. And for that experiment, they were looking at, they had 45 hospitals nationwide, and they were able to do an experiment using possible future methods of surveying our patients, which we have all said we need. We need some web-based methods of surveying our patients. So they had four web modes. So they had the web mode, web first, web mail, web phone, and web mail phone. And so they believe that this is possibly something we're going to be able to use in the future, because they did have great response from the web first type of surveys in this experiment. So, and on average, there were about 63% of 65% the email addresses were available to these hospitals. So it looks like they're moving in the direction of allowing us to have some web-based surveying capabilities. Right now, the mixed mode of having mail followed by the telephone in the experiment, that one showed the highest response rates. So that's something different from what we've seen before. This is just the front page of the HCAHPS survey. The latest edition was developed and came out in March of 22. Supposedly this one will expire in 24, but it's likely that they may make changes even before then. All of the core questions that are asked are all standard throughout the HCAHPS survey. They have to be standard for everyone. But then you can choose to add additional custom questions to your survey if you like. The problem with that is the survey is already long, and if we add more custom questions, it's just going to make it longer. There are 19 core questions. There are 3 that are just directed at patient relevant information, 5 that adjust to the mix of patients. And then there are 2 that support a congressionally mandated report. And then with those, the 19 questions are all your core questions. So the first composite, and some of these composites don't fall right in line with the way that the survey is outlined on paper when you see it in paper, because the composite, one of the composites may come from a different area, but it impacts this particular composite. So the first composite is the care from your nurses. And those questions are during your hospital stay. How often did nurses treat you with courtesy and respect? Listen carefully to you and explain things in a way you could understand. In this particular composite, there are several different best practices that we share with hospitals in our work that they can try to help improve. We definitely need to provide staff with training and promote awareness related to empathy, which is why I have empathy added to this presentation, and effective communication. Using teach back for your patients and limiting jargon. You know, we do have a lot of medical terminology and we need to speak to our patients in the way that they can understand. Ask Me 3 is a great health literacy principle that gives the patient 3 questions to ask us to help them really understand their care. We should standardize our shift change reports and bedside report. And that gives us an opportunity to help the patients and families engage in their care. Your responsibility is to ensure that your patients and family members or caregivers have the opportunity to be part of their plan of care. And so by having a bedside shift report that's standardized, and then that gives you the opportunity there to have those patients right there at the report and make suggestions around their plan of care. Implementation of your intentional hourly rounding, using whiteboards. They're a great option for communicating, especially your daily goals and your tentative discharge plans. And then use scripting. I'm not a firm believer in just, robot type scripting, but you can use basic scripting for, keywords at key times and employ that type of communication framework such as AIDIT. That's a Studer principle. And sit at the bedside when possible. Memorable conversations also will help your patients feel like they are more connected with you. Asking them about some of their personal things and their personal goals when they leave. What is their goal when they leave? Do they like to garden? Do they like to fish? What type of things that they like to do? And maybe, write that on the board. Mr. Jones can't wait to get out and go fishing. Just something that really personalizes their stay with you. The next composite is the care from doctors. And again, these have to do with courtesy and respect, how often the doctors listen carefully to you, and how often do the doctors explain things in a way you could understand. We're hopeful, and this has been a concern with many of our hospitals, we're hopeful that this will eventually be changed to providers, because many of our hospitals use a lot of advanced practice providers, and that should really say provider instead of doctor. Again, it's staff training, and that means your providers as well. Providers should be trained on all of the HCAHPS questions and what they actually mean. They should implement a peer-to-peer mentoring, using Teachback as well, and limiting that jargon, and using the Ask Me 3 health literacy principles as well. They should engage their patients and family members in their care conferences or the interdisciplinary rounds they may do. They too should consider using keywords at key times. And you should consider appointing a provider champion. It's really it helps a lot to get our other providers on board when we have a provider champion that's also supporting our initiatives to really impact our HCAHPS scores. Ensure that all of your patient feedback that you receive in your survey information is shared with your providers. They should all know if there are comments about them or if there's something where they're not scoring very well. And providing pads and pens or pencils at the bedside, that helps your patients. So when they're thinking throughout the day before they may see the provider, they can make some notes of some questions they may have or concerns, because you forget things, when you're there with the family member, you forget the questions you may want to ask. So that's a really good thing to add as well. And sit and listen. The statistics show that to sit and listen to your patients doesn't take any longer than a provider standing over the bed. And it also provides a much more of a personal aspect to their care. The next composite is your experiences in this hospital. So during your hospital stay, did you need help from nurses or other hospital staff in getting to the bathroom or in using a bedpan? Now that's a screening question. So if they did not need help, then they would move on to a different place. But if they did need help, then they would be asked, how often did you get help in getting to the bathroom or using a bedpan as soon as you wanted? Then part of this composite is also during the hospital stay, after you press the call button, how often did you get help as soon as you wanted it? So responsiveness of staff, that takes a hospital-wide effort. Everybody should be responsible for ensuring that no call bells go unanswered. So we should have some certain protocols and identify accountability for responding to the calls. So for instance, do you have a unit, a ward clerk or unit secretary or someone that can answer the call bell machine? Actually, many hospitals have removed that from the station so that they are they're more apt to have to get up and go into the room and address the call bell and why somebody's needing help from you. You should try to just for a period of time track in the type and timing of your inpatient request so that you can understand when are most of your call bells pressed. The intentional rounding is using the 4 Ps, 5 Ps, 7 Ps. I've seen several, but in this situation, pain, potty, position, and proximity. It has been known that if we do intentionally round, every hour that less call bells are pressed, because we've already addressed some of the situations that they may have. We should have processes and expectations regarding communication for nurses if they're stepping away from the floor when assistance is needed. So if someone is on break or lunch or has to go somewhere else within the building, there needs to be another person that will address their patient's call bells. It's not just our patient, it's everyone's patient. And practice the no pass zone. So hospitals can start what we call the no pass zone, and everyone in the hospital practices no pass. What that means is you may have environmental services coming down the hall, somebody from the business office coming down the hall, maintenance and so forth. And if they see a call bell, they don't go by that room. They actually knock on the door, introduce themselves, and ask if there's something that you can do for them. Now, we're not asking non-clinical people to do anything clinical, but that starts the conversation and you responding very quickly as to what they may need. If it's something that you can do, then do it. It may be that they've dropped their remote control, or they dropped something personal, or their bedside table has been moved and they need it back beside them. That's something that anybody can do. If they ask to go to the bathroom or so forth, then you can say, the person can say, sure, let me get your nurse or your tech or someone to help you. They'll be right back with you. And then make sure that they do. So the no pass zone does help, definitely helps that responsiveness measure. The next composite is your experiences in this hospital. Were you given any medicine that you had not taken before? Now, that's also a screening question. So if they said no, then they won't move on. But if they say yes, then the next question is, before giving you any new medication, how often did hospital staff tell you what the medicine was for? I mean, that should be very, that should be common practice, that we're telling our patients what we're giving them and what it's for. Before giving you any new medication, how often did the hospital staff describe the possible side effects in a way you could understand? So one thing that we always recommend is what they call M on the board. If a patient has a new medicine, on your whiteboard, you can just indicate an M. That is to acknowledge the new medication, and that way it's just a trigger for all staff that come to pass meds. This is a new medication, and we're going to continually educate. So you educate every time with a new med when you pass a med. That way they really get that communication about their medication and what the medication is for and what are the side effects and so forth. You can use TeachBack to assess the patient's understanding about their medication. Again, Ask Me 3, those are things that, and posters that are available from the NAHQ that you can post on the, no, it's the National Patient Safety Foundation, sorry, that you can post in the rooms. There are brochures about Ask Me 3 for the clinics and so forth. So this is something that can be used. There are free resources for you to use for Ask Me 3 and bring that into your hospital. Of course, limiting the use of jargon and technical terms, and making sure that we have nurse-ready access to resources and tools about medications in patient-friendly terms. Many of our hospitals, of course, have services within their software, within their system that prints out medication information. But is that medication information in patient-friendly terms? Would they understand it on their own? Providing a pharmacist at the bedside to visit the patients and review new medications. If you think about how many discharges you may have a day, if you need to, if your pharmacist is not, doesn't have a lot of time to go through every patient about all their new meds, Then let's do the discharges as they happen. Make sure that that pharmacist visits those patients that are getting ready to discharge and give them a little bit more information about their medicines. For some reason, when pharmacists speak with our patients, they seem to understand it a lot more than just having our nurses to educate. Make sure that your staff understand how to take care of situations that may come up if the patients, so for, if they don't speak English, or if they have difficulty hearing, you have to have a process in place before that happens to ensure that you're going to be able to take care of that. On our follow-up calls, let's inquire about their medications. Were they able to pick up their medication? Do they understand how to take it? Sometimes our patients get a little confused when they're leaving the hospital, so we need to make sure that they do continually understand. And consider the use of medication organizers. That's not much to ask for, to help them be able to kind of organize when their medications are supposed to be taken. I've seen in many hospitals, the discharge information has a calendar or a list, and they use the sun for daytime and the moon for nighttime. Anything that we can do to help them better adhere to their medication regimen. This composite is about when you left the hospital. So after you left the hospital, did you go directly to your own home or someone else's home or to another health facility? This is also a screening question. During the hospital stay, did doctors, nurses, or other hospital staff talk to you about whether you would have the help you needed when you left the hospital? Sometimes we fall pretty short on that. Unfortunately, patients get home and they really don't have the help they need. So we need to make sure we talk to them about that. Who will be taking them to their appointments if they don't drive? Who will be there waiting for them if they have stairs to help to get them in the house? Who will be cooking for them? These are things that we definitely need to focus on. During the hospital stay, did you get information in writing about what symptoms or health problems to look out for after you left the hospital? Again, those discharge instructions need to be very, very clear about what symptoms they need to look for that could, mean that they need to call their provider, and who do they need to call about certain things. I had a situation one time when my husband had surgery, and we got home, and here I am, a nurse, and I was looking at the information. He had a bad reaction, needed some help. So I'm looking at the information, and the doctor's office number, nobody's answering. And they have this call system, but I needed to speak to someone. There was no information on the discharge instructions about who to call for specific questions. And that's something that you can also add maybe on your discharge folders. If you have this type of question, this is the number you call in the department, and so forth and so on. So we need to make sure that we give them a great information about what to look for and who to call when they have an issue. So discharge information, let's conduct a pre-discharge assessment of the patient's ability or their family members or caregivers to provide that care. If they need help, are they able to really recognize any early symptoms and take action? What type of quality of life they have, any cognitive or functional ability factors. Those are things that we should do early in the game. Discharge starts on admission, so we need to really understand if that's going to be a problem. Conducting your readmission risk assessment is a huge, important issue there. If our patients are high risk for readmission, we need to make sure that we are on top of that and we're addressing that early in the program. So if they're high risk for readmission, instead of calling them back in 24 to 48 hours, we may want to call them back in 12 hours if it's still the daytime, or 24, the sooner the better, to make sure that we can check on them early. Develop that comprehensive shared care plan. Everybody should be involved in their care plans. And then, consider that patient's values and preferences, social and medical needs as much as possible. Work with that patient in the very beginning and that family member to provide them for discharge. What happens with a lot of families is if you don't start that tentative discharge and what their needs may be, when it's time to discharge and you say, your mother's going home in the morning, they're like, oh no, I have to work. I can't come pick them up. We need to start on this very early. We've also seen where family members say, yes, they're going to go home with them. They'll be taking care of them. And at the very last minute, they decide they can't do it. So these are things we need to discuss early on. Make sure your discharge plan is very easy to read, and that it only contains those essential education that they need for their health condition, and use plain language by guiding through the health literacy principles. You have to have admission discharge folders. Those are the best. You start them on admission with information that the patient has already needs to receive. Our patient rights, all of the information that's given through the business office and so forth. And then continue with those admission discharge folders throughout their stay, adding in new things that that you may have from education from therapy or education from the pharmacist and so forth, and sharing that discharge plan on the whiteboards. So this is just a little vignette through the Joint Commission that I found a few years back, and it was about a man. He was 68 years old and he had heart failure, but he was readmitted. And so he brought all of his pill bottles back in a bag, which was great. That's what we expect our patients to do. But all of his pill bottles were full. And when he was asked why he hadn't taken his medicine, he began to cry, explaining he had never learned to read and couldn't read the instructions on the bottles. So that's a really important point. We need to make sure that our patients can read. A lot of the elderly just shake their head like, yes, yes, yes. That's not a good thing. We need to make sure they truly, truly understand what they're supposed to do. And by the way, pill bottles still have very, very small print. So we need to make sure that they understand exactly what they're supposed to take when. If they can't read or their English isn't their first language, all of that can be very concerning. The next composite is understanding your care when you left the hospital. So during this hospital stay, staff took my preferences and those of my family or caregiver into account in deciding what my healthcare needs would be when I left. Preference is the key word there. When I left the hospital, I had a good understanding of what I was responsible for in managing my health. That's really important because our patients and family members and caregivers do have a responsibility, and we need to share with them what we want them to work with us on to help their health, help improve their health. When I left the hospital, I clearly understood the purpose for taking each of my medications. So in addition to the discharge planning strategies, because this all works together, discharge planning and that transition of care, we need to help our patients understand how they can use patient portals. If they're elderly, don't have a computer, don't care to, we can teach family members how to use the portal. We need to make their follow-up appointments to make sure that they have those prior to discharge, if at all possible. If you don't have a community care transition team, we like to call that joint health partners. We learned that from a hospital in Alabama years ago. Consider developing that care transition team within your community. That should include all of the different entities that touch our patients, and there are a lot within our community. Think about pharmacy, the clergy, EMS, and so forth, and get together and talk about the transitions and where you may see some gaps. Track and trend all of your readmissions and make sure you're screening for social determinants of health. Conduct those meaningful follow-up calls as I had described. Make sure that all the patients and family members get that list in a patient-friendly way of their medications and so forth, the dose route and so on. And make sure that the patients that may have complicated medication regimens, we have engaged pharmacy. That's really important because those that do have a lot of complicated medicines and so forth, those are just a disaster if they don't really understand what they're supposed to do. And focusing on our patients' preferences. The hospital environment, they have a couple of questions that are on their own. How often were your room and bathroom kept clean? And how often was the area around your room quiet at night? There are a lot of things that we can do. We just need to make sure, first of all, that we have roles and responsibilities assigned for cleanliness. Now, that doesn't mean that it is just the housekeeping or environmental services department's issue to do. We should all be helping to make sure that their rooms and the area around their room is kept clean. We also should do some go through and do some spot checks to make sure that we catch things that may not be done on a regular basis. And maybe consider adding a little tent card to the bed or the room. If the patient's leaving to go for a procedure or whatever, when they come back, that they can see that the room was cleaned and so forth. Also, having a card on the bedside table or within their admission discharge folders that let them know who to call if they need, if they have concerns or they need something for the cleanliness of their room. And make sure that all of our staff members have some training and orientation, communication standards. Again, maybe using AIDIT for a guide. I had mentioned the tent cards. You can use logs to identify patients that they complain about. Maybe they have some concerns about their cleanliness in their room, and then follow up with those patients specifically to make sure that we've addressed their problem and so that they understand that we are concerned. And then hourly rounding definitely would help with that as well. Quietness, if we can use single patient rooms, that's best. Also, let's ask our patients if they would like for us to close the door, if possible, and use quiet zone signs to remind everybody. Don't page overhead at night, and have a certain area for staff conversation. When patients are trying to rest, and that's what they're supposed to do to improve their health, we need to make sure that we respect that and that we are also quiet. Evaluate your transport cards and replace noisy wheels and casters. Turn down alarms to a degree that you can. Make sure that heavy machinery that's used, especially like those floor scrubbers and so forth and buffers, maybe are done during the daytime. And I know they say, well, they have a lot of staff out there during the daytime, but let's not do any of that around the time close to the patient's room. If you have to go into the patient's room, use a little flashlight or some other method so we're not flipping on lights and waking them up. And consider using a quiet pack. I think Medline has a quiet pack that includes like earplugs and an eye mask. Sometimes those are helpful. And then the overall rating of your hospital. That would be from 0 to 10, where 0 is the worst and 10 is the best. What number would you use to rate the hospital? And would you recommend this hospital to your friends and family? The following areas have been noted to most strongly correlate with the overall ranking of the hospital. But the pain management was one of those, and we know that one has been removed. Willingness to recommend. We need to speak positively about our organization, brag about what our strengths are, and thank patients for using your health system. So establishing high standards, building accountability has to do with the expectations, our service behaviors, job-specific service behaviors, our standards, and our service targets. So what our customers and consumers of care want from our service, that has to do with our behaviors, our processes, and our environment. We need to set standards around all of those expectations. What should health providers and staff do and say for and with customers? We should consider having a common language. And, I've referred to AIDIT a few times, and that is a Studer principle. And I'm not here to specifically push a Studer principle, but that's one that has worked really well for a lot of hospitals. To acknowledge, introduce, duration, give an expected time for certain things, tests, physician rounding, and so forth, and explaining to our patients so that they'll understand what's supposed to go on. And then always, always, always thank our patient. If you can see on the bottom, the Cleveland Clinic, the last one there is thanking. Always thank our patients for using your services, and acknowledging that that's really important to you and your hospital. Expanded from basic service behaviors are job-specific service behaviors, and those are what we consider fine-tuned job specifics. That has to do with service protocols, different scripts, roles and responsibility descriptions, and possibly standard work. Our service standards are promises that that your service makes to its customers. So based on the knowledge of what we know, and that can come from our survey comments, what your customers, which are our patients, what they want the most, as well as from norms for our service delivery. And that would be our best practices in our marketplace, which is the hospital and the healthcare system. It's an iterative process because things change, and what our patients and family members want can change, and it needs to be measurable as well. Service targets, we need to have goals established because they're really important. And it's important that we have goals so that we can strive to meet those goals. That way you want to improve over time. We always suggest, especially with HCAHPS scores or any of our quality metrics, we need to post these, and it's okay to post them in public areas. We want to share what our goals are and what we're trying to improve. That way it shows our patients and family members that we've acknowledged that, and we're trying to put different things in place to improve our scores and our standards. The role of empathy. This is one of my very favorite quotes. I've learned that people will forget what you said, people will forget what you did, but people will never forget how you made them feel. And if you have been a patient before in a hospital, or maybe one of your loved ones has, then you know that is very true. And so we need to keep that in mind when we think about how we're caring for our patients. There are a couple of different things to point at. The care for our patients, it's the patient satisfaction. And that's what we have been talking about with our HCAHPS scores. Patient experience is how you made them feel, not just the quality of care. We have to think about both. Empathy is the ability to understand and share feelings of another. And it had been quoted before as being probably one of the most misunderstood terms in the world of healthcare. Spiro said, "I might be you," or "I am you." That was the way that he kind of defined how you look at empathy. Empathy is not sympathy. It is known as the key ingredient to enhancing that patient experience. It's more than just that diagnosis and treatment of a patient. It is definitely thought to build trust, and it reduces anxiety and stress, and it can help our patients improve to their plan of care adherence. Sometimes it's not that our patients are just uncooperative or non-compliant. They just can't adhere because maybe they just don't understand. So that gives us a helping hand by using empathy. It also helps to improve outcomes, improves that communication, improves perception of the care that we've delivered, and it is the right thing to do. There are 3 types of empathy. Cognitive, that's when you can understand what the other person is feeling. Emotional, when you feel what your customer, which is our patients, are feeling. You can make a connection on a more emotional level. And then compassionate, when you are moved to take actions that happen to reflect the needs and wants of each person. So to demonstrate empathy, we need to be open to that patient's emotions and make at least one empathetic statement. Convey empathy non-verbally and be aware of your own reactions. Demonstrate empathy verbally with SAVE. That's just another acronym that came from, like we need another one, that came from the Cleveland Clinic. Support by saying, let's work together. Acknowledging it by saying, this has been hard on you. Or validating, most people would feel the way you do. And emotion naming, you seem very sad. It's really important that we show empathy. So take just a second and think about a place that gives you great service, beginning about what it does and what it looks like. I always use the example of Chick-fil-A. That's a little odd, but I love Chick-fil-A. I've been all over the country, and Chick-fil-A is always consistent. They are consistent in their message. Those that help you, whether they're in the line or at the window, and they always say, my pleasure. Now, if we can teach, and most of these are high school and college students, how to demonstrate that type of service, then we should be able to do that too within our hospital environment. Think about what wows you and why it does. It's a beautiful and mysterious power that one human being can have on another through the mere act of caring. A great truth, the act of caring is the first step in the power to heal. And that's by Philip Moffitt. So I'll close there. We have about 10, 11 minutes left, and take any questions or things that may be in the chat box that you may have.
Yes. Hi, this is Cassidy. That was excellent. Thank you so much, Dr. Wilbur. We do have a couple of questions in the chat. Let me just kind of look through them. So someone asked about CEUs, and we do not have CEUs for this particular webinar, but keep asking because we do for some. And yes, the slides in the recording will be made available. But then there's a question about the presentation that says, I'm wondering what set of questions directly correlate with care transitions.
Okay, so let me go back, okay? And I'll show you that.
And he could have asked before you got to that section.
That's okay. No, that's perfectly fine. So let me get back here. So this is the composite that relates to care transition. This is about the preferences of those of their preferences and those of their family in deciding what my healthcare needs when I left. So this is all about, transitioning out. And then when I left the hospital, I had a good understanding of the things I was responsible for in managing my health. That's been a question from many organizations, but the way that I've seen that definitely show that the hospital has kind of grasped that particular question is to create a partnership. So when they're doing their discharge plan and working with the patient and the family members, then, this is a partnership, explaining to the patients, we're partners in this care. And we are dependent on you to take these medicines like we've described them. We're dependent on you to get to that doctor's appointment. And if you have any problems with that, you need to let us know, or let your primary care office or specialist know that you're having transportation issues, things like that. And then when I left the hospital, I clearly understood the purpose for taking my medications. So all of these are what CMS has come up with to this date of what they believe would help in care transitions. And I'm a firm believer that care transitions and discharge planning all go together. It's really important that we use all of the elements of both the excellent discharge planning to help with our transition of care. Now, transition of care is still the lowest HCAHPS score across the country. So we haven't figured it out yet. But there are a lot of different hospitals who have done a lot better job with that. One of the hospitals that I worked with a few years ago developed their admission discharge folder had a place in it that said my transition of care. So they just really spoke to, we're starting this planning early to help you have a better transition of care. And that means to your home, your family's home, or wherever you're going. Did that help to answer that question?
I will assume yes, unless that individual asks a follow-up question. But if you do have a follow-up question, please don't hesitate to unmute or type it into the chat, and we'll make sure we circle back. He says yes, it was great, thank you.
Oh, good.
And then I got a message that said, please report the resources for Ask Me 3. I think you mentioned that a couple of times, and I would be happy to drop some links into the email that we follow up with, if that's helpful.
Absolutely. That's on the National Patient Safety Foundation, NPSF. So you can go to their site. They actually have posters, brochures, videos, and a lot of information around Ask Me 3. And all of the, I won't say all of it, but when I looked the last time, all of it was all free of charge. You just never know what people are doing every day, but that was all free of charge, that you could get this information. Some of it you can even print, and others you would need to order.
And the Ask Me 3 originated from the Institute for Healthcare Improvement, so IHI. So maybe that's a place. A lot of times they have a lot of those posters and resources and brochures to access online as well.
Perfect, thank you. Let's see, I don't see any other questions, but we still have a couple of minutes. So I did drop a link to a survey into the chat for everyone. It's about 60 seconds. It's on the webinar. And then I believe we also asked if there are any other topics that you might like to see a webinar on in the future. If you have a moment, we would appreciate you completing that. I don't see any other questions, so I think we'll go ahead and adjourn. But if you do think of something after we end the webinar, please don't hesitate to send me an email or respond to the email that we will be sending out to you guys, and I would be happy to get back in touch with Lindsay or Carla with your question. But I think
they can also, if they want to email us through Stroudwater, that's perfectly fine.
Oh, thank you. That's very generous. So you have that option as well.
And Cassidy, sorry, just also a reminder about the second webinar around improving your HCAHPS survey returns. That will be next month.
So correct. Thank you so much, Lindsay. So this is kind of one of two webinars on HCAHPS that Lindsay and Carla are doing for us. And the next webinar is on October the 11th, and that is improving HCAHPS survey returns. So make sure that you register for that. I will include the registration link in the email that you get. Give us about a day to get it posted to our website and sent out to you. So you should expect that tomorrow. But thank you for reminding me. I hear some dinging. Okay, nothing else. All right. Well, thank you so much for joining us today. Thank you, Lindsay. Thank you, Carla. We really appreciate it. That was a fantastic presentation, and we will see you all next month.
Thank you. Thank you all.
Bye, everyone.
Bye-bye.